Speaking here with Jim Capretta, who has co-authored with me a paper on a defined contribution route to healthcare reform. Jim, everybody knows about the way we've done health benefits in the past. Promise people things and find some money to pay for it eventually, and that's true in Medicare, in Medicaid, and with the subsidies through the tax code for what's been largely employer-sponsored insurance. You're suggesting a need to rethink this for important reasons. What's behind that?
Well, I think there's an element of the health debate that's really centered on what are we going to do about the cost side. I mean, what are we going to do about slowing the pace of cost? And there's a conversation about how to improve the productivity of the health sector. And when I look at it, and I think a lot of people who've tried to promote a functioning marketplace for healthcare, when they look at it, they realize that at the margins, the consumer in American healthcare is largely insulated by cost because of the way Medicare is designed, the way Medicaid is designed, and the way employer insurance works. On the margins, for every extra dollar consumed, the federal treasury is picking up a pretty big part of the costs in each instance. Moving toward a defined contribution system allows the federal government to still have a policy of coverage and broad-based plan enrollment without having on the margins this kind of bad incentive for extra use and extra consumption. What you do is change the entitlement structure, change the tax subsidy to give people a fixed amount of resources, and then ask them to make some choices with those resources. They still would be able to get coverage, of course, within some serious oversight by the government, but the actual allocation of resources, where they would use it, would be more up to them than the government. That's the way to kind of incent the delivery system then to respond, to be more productive, to give them more value for the money, their fixed amount of money that they have. So I think this flipping the equation toward this kind of a defined contribution approach is the key actually to moving toward higher productivity in the health system.
This seems like a big change given the structure of where we've been. Can we do this? How can we do this? And how does it begin to change?
It's a huge change. I mean, we shouldn't kid ourselves. This would be a sea change in American healthcare. And that's why it hasn't been done in the past. It's a difficult thing. It's been proposed in a number of contexts, and it's gotten a lot of conversation. In 1999, there was a bipartisan commission that recommended this for Medicare. Senator McCain proposed this as one of the concepts in the employer system during the 2008 campaign. But no, it hasn't been brought forward yet. But I think we're at a point in our country's history where fiscal problems, healthcare problems, people are realizing that more fundamental things are going to have to change. If you just look at the nature of the recently, the debt commission led by former Senator Alan Simpson and former Chief of Staff to President Clinton, Erskine Bowles, they put some ideas on the table that people thought were not really viable even a few weeks ago. So the conversation is going toward bigger change and bigger ideas, and that's driven by the fact that the country is entering a new phase in our economy. We have to make big structural changes in our entitlement programs to make sure that they can be afforded in the future years.
Thank you, Jim Capretta, co-author with me of a new paper in our Beyond Repeal and Replace project at AEI on defining the defined contribution route to health reform and even more ahead. Thank you.
Thank you.